Surgery for pterygiums is indicated whenever the pterygium is affecting the central visual axis or it's not responsive to medical treatment. Requires complete excision with careful dissection medially most often, and good primary closure. A large autograft, rotational graft, or amniotic membrane grafts have been used, but leaving bare sclera is no longer considered acceptable. Fiber and glue can be used, or sutures can be used, and that's surgeon preference. Other things to consider are glaucoma status, so that if you need to harvest superior bulbar conjunctiva, you may prefer to choose something like amniotic membrane as an alternative if the patient may need a trab in the future. Ocular surface reconstruction is indicated in severe cases of patients like Stevens-Johnson's, ocular cicatricial pemphigoid, and chemical injury. The techniques include using autologous conjunctival grafts, buccal mucosal grafts to reform the mucous membrane surface, and often amniotic membrane. It's important to understand the concept of staging the procedure. So when you have a severe ocular surface damage, like Stevens-Johnson's, you have to basically till the soil before you plant the seed, which means you have to prepare the ocular surface well before you consider a transplant. Transplants will fail without a healthy limbus. And the healthy limbus will fail without a nice moist corneal surface. So you have to prepare the ocular surface. You have to have a good healthy limbus before you can consider doing a transplant. And even if you're not going to do a corneal transplant with human tissue, you're going to use a capro, you still need a nice wet surface. So you need to, you can't do a standard type 1 capro in a keratinized epithelial surface. They typically do poorly. We'll talk about that in a minute when we talk about capros. So ocular surface reconstruction can consist of all those things. Limbal stem cell transplantation is one of the mainstays of treatment for this. You have to first identify limbal stem cell deficiency, which is again seen with an irregular epithelium, loss of the palisades, pannus and goblet cells on impression cytology. It's often not that subtle, especially in the severe cicatrizations. It can be unilateral or bilateral, and that's important because if it's unilateral, you can often harvest tissue from the other eye. In bilateral conditions, you must use an allograft. Allografts, of course, have a better survival rate. Conjunctival flaps are indicated in situations of a sterile, non-healing defect, such as illustrated here in this photograph of a dell. So this is a severe limbal dell and a conjunctival graft immediately postoperatively in the second photo, and then late post-op, which shows vascularization and conjunctivalization of the peripheral cornea. It's used in painful bullous keratopathy and in preparation for a scleral shell. You do not want to use a conjunctival graft in an active infection or a leaking perforation. So this again is a key when you're presented with a clinical scenario on your boards. You do not want to use a conjunctival flap when there's an active infection or a leaking perf. Techniques that are important to know are the Gunderson flap, which does require some attention to detail. It's basically taking the superior bulbar conjunctiva, creating kind of a bucket handle to it, so you create a superior and inferior limbal peritomy. Dissect posteriorly at least 10 to 12 millimeters of the superior limbus, and bring that conjunctiva down over the cornea. You have to destroy the corneal epithelium and stem cells entirely for that to work well. And that's typically, again, done in a blind, painful eye in preparation for some type of scleral shell.